have pursued using parents as donors that are half-matched to their child, and their child has high-risk features of sickle cell disease. And our approach involved a novel way of conditioning the patient to assure them that they weren't going to reject which was a half-matched donor. And secondly, we did some cellular engineering of the stem cell graft from the parent so that we tried to maximize engraftment and minimize the complications such as graft failure or graft versus host disease. And so our results show that we have a 1-year 90% survival rate. And then when we look at the patients, we have a median follow-up now of 3 years of this approach. No patient has signs or symptoms of sickle cell disease, and they have significantly improved neurological, cognitive function and improved quality of life, and they have stable to improved organ function throughout. So because we're doing cellular engineering, we specifically take out a large number of the immune cells that cause graft versus host disease in this particular study because it's a half-match study. In the matched sibling donor studies that have been done, because the risk of GVHD wasn't as high, almost 100% of them had what we call T-replete grafts, meaning their full immune cells from their donor was given back to them, and so they do have an incidence of 15 to 20% of acute graft versus host disease and the same of chronic GVHD. So ours is lower because we specifically do engineer the graft. And I think the standard now would still to use an HLA matched sibling donor who doesn't have sickle cell disease. But when you work through the numbers, even with the normal Mendelian expectations of 1 in 4 in a family should have a HLA matched sibling, some of those actually have sickle cell disease. So the numbers really fall down to about 1 in 6. So 5 of 6 patients who might benefit from an allogeneic transplant will not have an HLA matched sibling donor that doesn't have sickle cell. Well, in the beginning, we obviously were conservative and had very strict stopping rules because we didn't know whether this would be more risky than an HLA matched sibling donor transplant. As it turns out now, and again, smaller numbers than been done over the last 30 years with HLA sibling donors, the results are identical. So that it's not showing that there's any more risk in doing a half-matched parent as a donor than using an HLA matched sibling donor. Of course, more numbers will be needed to confirm this preliminary finding. So the bottom line is that we can cure over 90% of children who have high-risk features of sickle cell disease by using the parent as a donor with our novel approach of conditioning and our novel approach of cellular engineering of the graft before it goes in, and that they essentially, once they survive, they become sickle cell disease free, no symptoms, no signs, and no further progression of their sickle cell disease, and in fact have a significantly improved quality of life and also neurocognitive function. We're in a second study. This again is being supported by the FDA as a grant, R01 grant. Here we've done a couple of things. We've expanded the age limit from 21 years of age to 35. And because the study was so successful in terms of 100% engraftment, we've actually lowered some of the doses of the conditioning regimen so that down the road in the future there might not be any late effects from that. And because one of the risks in the older patients is a complication called veno-occlusive disease of the liver, they're all receiving a drug called defibrotide, which has been shown in Europe at least to be effective in prophylaxing or preventing the risk of VOD.